very much. So, as the World No Tobacco Day is coming closer and closer, so today we'll be talking about tobacco and oral cancer, the overlooked connection. So, the very first thing, why does this topic matters to us? The important thing to understand is that oral cancer, cancer per se, is the second leading cause of mortality, with over 9.7 million cancer deaths and roughly 19 million new patients with cancer globally. India basically runs third when it comes to new patients with cancer, irrespective of the site, gender, or the age group. So every year, basically, 14 lakh new patients are diagnosed with cancer. Now, if you talk about which cancer are we particularly talking about, so if you just see that in males, if we simply just look at the figure of oral cancer, as you can see on the top, it is roughly 15.6%, is almost one fifth, roughly one fifth, are oral cancers in males in India. And in females, roughly 5% are oral cancers. So, and this highest incidence of tobacco related oral cancer, which we see, is generally in the low and the middle income countries. And our nation belongs to that particular group. And people in the lower socio-economic strata are the most commonly affected. In India, almost 21 people per 1 lakh of the population are affected. So the number with which we are dealing as far as oral cancer is concerned is a huge number. Generally, whenever we talk of tobacco and these, generally most of the people think only the only thing which comes to their mind is lung. But no, oral cancer is a huge number, and the number of patients are quite large in count. Now, when it comes to tobacco usage in India, you will be amazed to know that this usage is the leading modifiable factor which is contributing to cancer incidence and related death, and it ranks second both with respect to tobacco production and consumption worldwide. So India is not just topping with respect to population, but even with respect to tobacco usage and production, we are the second largest. And the consumption of both the smoke as well as smokeless tobacco are maximum in our particular nation, with the use of smokeless being the highest, even much more. So current tobacco usage stand at 32.8% in India, out of which almost 24.7% are smokeless tobacco users. So when we say smokeless tobacco, we basically mean gutka, khenny, snuff, betel quid. These are much more popular. Whereas smoked tobacco, when we talk it about, it is about BD, cigarettes, and hookah. And this usage in youth is very, very high. So when I say that the connection is overlooked, what do I mean? So there are few things which one must understand, that with respect to tobacco usage, particularly in India, there is kind of a social normalization. I'll talk about each one of these one by one. And the possibility of delayed diagnosis in oral cancers is quite high. Patients ignore symptoms, and there is also a lack of screening. That is why this particular connection is quite overlooked. Now, if you talk about social normalization, we all know that in our normal locality also people are consuming a lot of smokeless tobacco and smoking, but it is considered more of a social binding agent, social bonding. So despite national laws regulating sales and placement of pictorial warnings on the packaging, tobacco products are still very cheap. That is why you must be seeing that presently government is trying to increase the cost of tobacco related products. And this normalization, what has done is that because everybody is doing it, so people underestimate the carcinogenicity of these products as far as oral cancer is concerned. Now, second is symptom ignorance and delayed diagnosis. Now, whenever we talk of oral cancer, the initial presentation is that of a non-healing ulcer or white or red patches in the oral cavity. Uh, so generally these are painless. Now, because they do not hurt, generally people dismiss them as minor infection or dental problems. And third is lack of screening. Now, if you have a look at this particular paper from the Maulana Azad Medical College, you just read this. that from August 23 to June 24, total 116 adult patients with biopsy proven oral cancer were recruited in this cross-sectional study. And if you read in this second paragraph, you will see that most consume tobacco daily, while 52% roughly quitted tobacco consumption after getting diagnosed with cancer. But only 66% were aware of the link between tobacco and oral cancer. So roughly one third patient did not even knew that tobacco causes oral cancer despite the packaging and the advertisements what we see. And this particular thing is basically also you can see that the awareness of free government screenings is also very low, 0.9%. So this is why this particular connection is quite overlooked. Now, before we proceed ahead, how to deal with this situation, one must know that how tobacco causes oral cancer. So this is how it causes that all these tobacco related products have basically these compounds called as benzene, formaldehyde, nitrosamines, which causes DNA damage. They cause a mutation, cellular changes, and along with a bad oral environment, these basically result in precancerous lesions and cancer. And there are high risk habits like chronic smoking, use of smokeless tobacco, reverse smoking, or taking alcohol in synergy with smoking. So all these factors further proliferated. Now, there is something also known as a molecular and field cancerization. As we know that whenever a person consumes tobacco, the whole oral cavity, the gut, the upper aerodigestive tract is exposed to these tobacco carcinogens. So this entire area is basically the mucosa is undergoing changes which can develop into cancer. So there are multifocal changes. So even if patient recovers from one cancer, say he or she develops a tongue, he can eventually end up developing esophagus also or a lung cancer also. These are referred to as second primaries. And all these tobacco, the DNA changes, what they basically end up doing are TP53, which is a gene mutations which result in this particular form of cancer. So whenever a patient has basically these four things, either a non-healing ulcer, reduced mouth opening, white or red patches in their oral cavity or any neck node, then all these are red flag signs. A non-healing wound for more than 3 weeks or these factors, then he or she must report to a doctor. Now, this is how these clicks. See, this is a non-healing ulcer. This is a whitish patch. This is a reddish patch called as erythroplakia. This is called as leukoplakia. And this is the patient is not able to open the mouth. This is called as a submucosal fibrosis. So these are the signs. Now, once you detect it, now the detection thing basically will be possible only when there is awareness about this particular thing. And secondly is screening. So screening is basically conducted by Government of India under the National Program for Prevention and Control of Non-Communicable Diseases, in which a simple oral visual examination is done. And another important thing is counseling. Counseling of the patient regarding the need for a regular checkup. So if you see the benefit of this, you see this study in Kerala by Shankar Narayanan. They they did a RCT on 96,000 patients. And oral visual examination resulted in 35% reduction in overall mortality. So this is how beneficial screening is. And similarly, now screening has some flaws also. Now say this is another study by Walter in which they did 3,000 biopsies. Out of that, 20% showed dysplasia and roughly around, if you say 4.6% only had some form of carcinoma or something. 3% had an unsuspected squamous cell carcinoma. So you can understand that if I do a large number of biopsies after doing a oral visual examination, there is quite high possibility that it might come negative. So we have to counsel the patient that please still do come for regular checkups. It does not mean that you don't have or you will not eventually develop cancer. So you just need to get it rechecked again. So this is how an oral visual examination is done, in which all the subsites of the oral cavity are checked. So management wise, once you see the red flag sign and the patient presents to you, you do an imaging of the patient depending upon the site involved, and then you do a biopsy of the patient. So imaging can be either a MRI based on generally for tongue and soft palate, whereas a CT for to delineate any bone involvement, and a CT chest, in particularly in cases where the disease is more or there is lung mets are suspected. Now, this is a general treatment plan. So, if the disease is localized, an early disease, surgery is the preferred form of treatment. If the disease is locally advanced, then upfront surgery can also be done, or a patient can be treated after giving chemo. So, overall, but if the disease is metastatic, then chemo needs to be given. So, one of the most important things which one must understand prior to actually understanding this entire treatment plan for cancer is that tobacco cessation has a very important role. But if you see that within 5 years of quitting, even after 5 years, the risk of developing is only reduced by half. And it takes roughly 10 to 15 years for the risk to approach that of a non smoker. So the government of India has also implemented in 2008, they implemented the National Tobacco Control Program in almost all 36 states and union territories, in which the prevalence of tobacco by implementing this was reduced to 28.6%. And they how they help is they send you messages regarding tobacco cessation, or you see the TV programs in which they, before prior any movie or in even on TV, you see, and even banned electronic nicotine delivery devices like vapes and everything. And there are non-governmental organizations also which are working towards tobacco control in our country. So in the end, I just want to say that even before you develop the disease, cessation is the key. Quit smoking, quit tobacco products, and live healthier and live better. Thank you. Any questions, please?